Yeah, we are live.
Hi friends, good evening to you and welcome to Indian Arthroscopy Society webinar. It's a webinar which is quite interesting one because we have our friend, a Japanese colleague, whose name is Dr. Hiro. And Hiro Sugaya is world famous in instability surgery, and his work on Bony Bankart is is treated itself as a treatise. And it's it is an honor today that Ashish Babhulkar, our friend from Pune, has coordinated with Hiro, and they together are doing this master class on bony Bankart and bone loss in shoulder instability. May I ask Ashish to briefly introduce Hiro, because he has been knowing Sugaya for a couple of years now, and his take on shoulder instability, and then we can, till that time, Dr. Sugaya can join from Japan. Ashish, please.
Yeah. Pradeep, can you allow me to share the screen? I will put up Hero's presentation.
Yes. I think you can share directly. I don't need to.
Oh, host has disabled attendee screen sharing.
1 minute. I think Sandeep.
Sandeep?
1 minute. 1 minute.
Best is to make Ashish sir a co-host, no?
Yeah, I'll make him co-host. Yes.
So he would be able to manage.
Yeah.
It will be easy for him to manage.
Yeah.
Yeah.
Yeah, Ashish.
Yes, got it.
Pradeep, we are live already, na?
Yeah.
Yes. Right. Good evening. It's a pleasure again to come back to this IAS program. It's a great pleasure to invite Hiroyuki Sugaya, who doesn't need any introduction at all. He's a dynamic figure. He's been a friend of India for several years. For those who are not aware or not in the loop, he is the director of the shoulder elbow service at Funabashi Orthopedic Sports Medicine Center. This is in Chiba near Tokyo, and he has a phenomenal practice of shoulder surgery among sportsmen, baseball players, does a lot of elbow work, and also does a lot of reverse shoulder replacements. Looking at him, this is a photo that is from IS Goa 2006, and you can see that he's ageless. He's just the same all these years, and you don't have to ask his age. He's a avid golf player. His handicap is amazing. He can share his skills with professional golfers also. Basically, he's known for his surgery on bony Bankart repair and integration of the bony fragment. It's a phenomenal lifetime work. And that's why we thought it was important to bring up the counter narrative, because in the last 3 weeks, we have been with Chodibier, we've been with Pascal Boiler, we've been with Lauren Lafosse, and the whole emphasis has been Latarjet. Today, I think the Latarjet is not the important topic. What is important is to soak in Sugaya's contra narrative on these difficult sportsmen. So even he's dealing with a lot of contact athletes, and he's doing them with the non-Latarjet option. That's why it's going to be a very interesting talk. He has a patented instrument called a bone stitcher specifically for the bony Bankart, and he prides in his fitness. Amazing, he cycles to his work all the time, and he's been to India several times. He's a great friend of India. In fact, the first IAS that was done at Coimbatore, Sugaya was the faculty, and since then he has been to number of meetings here. He's also operated at the Shoulder Conclave. So this is the brief introduction of Hiro Sugaya. I cannot do justice to him in a brief minute, but we will continue with the program today. So this is his recent photo from 2017 NSE course. Right, so with the permission of the chair, I think we'll continue with the talks here right now.
Dr. Sugaya has joined.
Yes, I'm here.
Hero's here?
Yeah. Hi, Hiro.
So let us wait. So, Hiro,
Yes.
konnichiwa,
Konnichiwa.
arigato gozaimashita. Thank you very much. We've just finished your introduction. We would like you to take the first lecture on the Bony Bankart, and then I'll come up with the next talk.
All right. So
please optimize the video screen when you share the screen. There are two chat boxes down.
Okay. Can you see my video?
No, not yet.
Not yet.
Okay.
Yes, starting.
Yeah, starting.
Lovely. Okay. We got it. Just put it on show. Yeah, perfect. Please go ahead.
Okay. Okay.
Yes, lovely, perfect.
Okay. So, okay. I will speak about the Bony Bankart, management Bony Bankart first. And chronic traumatic shoulder instability. Can I proceed this?
The arrow?
Yes. I cannot proceed my video.
Next. No. Next. You just click on the screen once, Hiro.
Yes.
And then.
Okay. All right. Just quick. This is my disclosure. Okay. Recent trend in shoulder stabilization for soft tissue chronic shoulder stabilization, soft tissue Bankart repair, including Bony Bankart repair, and also the bone grafting. And a soft tissue Bankart repair is recently many people think that not reliable, especially in collision contact athletes, and also in shoulders with off-track lesion. However, the bone grafting, including Latarjet, ear crest grafting, and tibia, especially the Latarjet is becoming gold standard for shoulders with off-track region. So my personal experience is that I'm quite satisfied with my soft tissue Bankart. More than 95% of my series, arthroscopic Bankart or arthroscopic Bony Bankart repair with or without soft tissue augmentation. So less than 5% of the series, I do bone grafting only for severe bone loss without Bony Bankart for bony fragment in active patient. So soft tissue Bankart repair is anatomical, least invasive, positive function excellent. Everybody agree with that. Bad, high failure rate. So this is simple and easy, but not reliable. I think many people, many surgeons misunderstanding. So this is not simple surgery. This is very, very difficult. This is technically demanding surgery, and also tissue tensioning and also the augmentation are the keys for successful soft tissue Bankart repair. So this is not simple Bankart labrum repair. This is totally different from labrum repair. This is an arthroscopic capsular shift procedure. So my soft tissue Bankart repair is first I release the labrum all the way down to the 7 o'clock in the right shoulder and remove the cartridge at the face of inferior glenoid and insert at least 4 anchors and tie the suture like this and provide tension to the entire ligament. So this is a typical soft tissue Bankart procedure. This is a right shoulder, Hiroyuki region. You see, this is a view from the anteropolar. You can see the Bankart region locates only 2 to 5 o'clock, but I try to release the ribbon all the way down to the 7 o'clock using scissors like this. And this is after release, and I also remove the cartridge at the face of the glenoid and inferior glenoid. And the release like this, and this is a view from the anteropolar. You can see this is extensive ribbon release is very important. Then I insert anchors and provide and prepare in labrum, providing tension to the capsule. So you see, this is the final reconstruct of my repair. So this is typical glenoid morphology in recurrent shoulder instability. So this is 3 subtypes. Actually, we published the papers and by investigating 100 chronic shoulder instability, normal glenoid, bony Bankart, and erosion. Prevalence is 10%, 50%, 40%. So this is very interesting findings, but what's the difference? What's the difference of these morphologies? So that's why in order to investigate this, we investigate another 200 chronic shoulder instability. With the contralateral side is normal using these shoulders, including 140 males and 53 females. And we did the EUA on the normal side in order to assess the constitutional joint laxity. Now the joint laxity is assessed by the EUA on the other side, contralateral side, and we graded from the 4 grades, classified into 4 grades, from grade 1, very tight shoulder, and grade 4 is a very loose shoulder. We have 58 grade 1, 44 grade 1, grade 2, 68 grade 3, and 30 grade 4 shoulders. And this is glenoid morphology versus joint laxity. You see, this is very interesting. Okay, so this is a grade 1. It has a bony Bankart is predominated, and also the grade 2 and 3. This is intermediate joint laxity, a constitutional joint laxity, and a normal erosion. Erosion shoulders predominated, and also the interesting read is on the gender. And when we compare the glenoid morphology to gender, and the females are predominant bony Bankart, and the males are predominant bony Bankart. The females the predominated erosion. And the dislocators, subluxators, the bony Bankart, erosion is predominated the dislocator, and the bony Bankart, and normal shoulders predominated, and bony Bankart and normal shoulder. So we, based on this study, that we interpret it like this. Shoulders normally, there are a lot of shoulders, from tight shoulders, from lax shoulders. So bony Bankart normally occurs in patient with a tight, who has constitutionally tight shoulder, and external high strength, very high strength, high energy external force created anterior limb fracture, and even after reduction, because of anterior limb fracture, it ends up in subluxator. On the other hand, normal shoulder can very easily dislocate by the very small amount of external force, like this, and then after reduction, it ends up subluxator because this joint capsule is constitutionally very loose. On the other hand, erosion shoulder dislocates with the intermediate external force, and create the Bankart region and the erosion, attritional glenoid, and also Hiroyuki region, and ends up in dislocator. So that's why we interpret the glenoid morphology like this. And this is 558 athletic shoulders. The prevalence of the distinct bony Bankart region was averaged 4%. But interestingly, the rugby American football players and the martial arts judo players and the snowboarders, these patients tends to have a high energy external force. Their prevalence of bony Bankart region is very high compared to other athletes. So this is a large, normally this is a left side is a normal glenoid, and interestingly, most of the inverted pear type glenoid retains bony fragment like the right two pictures. This kind of the no attritional glenoid with a large bone, inverted pear type glenoid is very rare. So what about chronic? What about the bony Bankart region? This is a chronic region. The fragment becomes smaller with time. So it is true, and also fragment connects firmly to the labrum with the labrum, like this. So we can utilize the fragment and without removing it during surgery. So how do we manage the fragment? If the fragment is very small like this, then we can pass around the fragment. If the patient has a large fragment, we can penetrate the fragment. So in order to penetrate the bone fragment, the way I made a bone stitcher with the help of Smith and nephew. And this has very large handle and the sharp tip. And a portal placement is I use 3 portals, standard posterior and anterior portal, and also other superior portal as a working portal. And also interestingly, because I use 2 portals from the rotor in the rotor interval, so I use anterior 2 portals as a cannulas. I don't use cannula. So bony Bankart, bone fragment is expressed inferior and medially like this, so we cannot see even by the scalp. So that's why the preoperative CT is very important to assess the bony fragment size of the position and the shape of the bony fragment. So technical parts include the extensive complexities like I showed previously, and also the inferior labrum repair. This is the first I repair the inferior labrum rather than relative to the inferior portion of the bony fragment. Then the bone fragment comes up cranial side, then they're gonna be very easy after repairing inferior labrum. The bony fragment management is very difficult, but it makes that very easy. So fragment management using a big grasper, introducing big grasper from the standard, anterior portal and the bone stitcher. Okay, so this is the complex release. The IDD is a complex all the way down to the 7 o'clock. I remove the cartilage at the face of the inferior glenoid. This is exactly the same as soft tissue Bankart without bony fragment. And I inserted 2 anchors relative to the inferior, more inferior to the bony fragment like this, and I repair the inferior labrum like this. And then finally, I try to repair the bony fragment. Now the bony fragment is penetrated by bone stitcher coming from the standard anterior portal, and also a big grasper is introduced from the anterior superior portal in order to hold the bony fragment during the bone penetration. This is the final repair. So we published on longer term outcome, JBJS 2015. 85 shoulders underwent arthroscopic bony Bankart repair from January 2005 and to December 2006. We chose 46 shoulders with more than 50% granular bone loss without regardless of the fragment size. And we 38 patient returned, and we followed up for the 38 patient. And among those, only 1 patient recurred due to the major trauma before obtaining bone union. So this is the case 1 that this patient has a relatively large fragment. You can see the very nice bone union. And also, interestingly, I want you to see that the fragment position is very cranial, more than cranial than anatomical position, because this is very important, because I provided proper attention to the ligament. So that's why the fragment position is relative to the more than cranial than anatomical position. This is case 2. This patient has a relatively small fragment, but the 8 years after surgery, interestingly, the bone remodeling, not just the fragment reduction, and also this procedure can induce new bone formation by remodeling. Okay, this is a granular bone loss after surgery. Preoperatively, 77.8% when compared to normal size, was the native glenoid volume, and 4.7% was the fragment size. And you can see that the native glenoid grew to the more than 100% of glenoid. So this is a very interesting outcome. So the why so successful bony Bankart repair? The patient with bony Bankart tends to have the constitutional stable shoulder. So that's why I think bony Bankart repair works very well. So the glenoid tract concept is very important bipolar bone loss concept proposed by the AG and this is very interesting. But they insist that the on track and off track is very important. And also they insist that the 83%, we need to subtract 17% because of the soft tissue, the laxity. So how do we manage the off track region bone, the shoulder? Is bone grafting is the only solution? No. I think the bony Bankart like this, substantial size of the bony fragment, we can, the candidate of the off-track region treatment is arthroscopic bony Bankart repair is a very nice candidate if the patient has substantial size of the bony fragment. What else? I think soft tissue is very important. So they said, they insist always 83%. They insist that the 70%, we need to subtract 70% the real from the glenoid tract. Then but I don't think it's always 83%. Because some is 80%, some 90%. So that we need to increase this number. So let's look at the rotator cuff and the joint capsule anatomy. Rotator cuff and the glenohumeral joint capsule is very anatomically very adjacent structure. So we cannot separate these very easily. So this is an interesting study. According to anatomical study, they proved that they demonstrated that the inferior pouch of the glenohumeral joint is the thickest when compared with other portion of the joint capsule. So the inferior capsule is very, very thick. So this is the MR arthrography for shoulder when shoulder instability before surgery. So this is, when we look at these pictures, this is very interesting. Here there's no surrounding rotator cuff muscles because of the inferior pouch, but instead the capsule is very thick based on the anatomical study I show you now, and also the other portion, the very thin place is here, rotator interval. There's no capsule, or there's no surrounding rotator cuff muscles, and also the very thin capsule. So that's why don't we close this opening? So that's a very understandable rationale of the rotator interval closure. So my rotator interval closure is the bracing suture through the subscap tendon, like this. And when we look at the rotator interval closure from the passer, this is a procedure to bracing suture to the both loop of the coracohumeral ligament. Actually, coracohumeral, one loop of the coracohumeral ligament originates from the base of the coracoid and inserts to the subscap tendon. The other one is the originates coracoid and also the inserts to the supraspinatus. So the first we brace suture subscap tendon, then we bring the arm maximum external rotation more than 60 degrees of external rotation side, and the bracing suture like this. This is our rotator interval closure. So I think by doing this, I think maybe we can reduce the biglenohumeral joint volume, and we can also induce the biofeedback through the restored proprioception by the ligamental retensioning. So I think this is a very effective procedure. But why rotator interval as augmentation is less popular? The lack of evidence. And also, importantly, the several review articles demonstrate that reported procedure is quite inconsistent. Procedure itself is quite inconsistent. I place suture to the subscap, but others don't. So that's very, very inconsistent. And also, several biomechanical studies demonstrate little or no effect. So our rotator interval closures, I started the rotator interval closure since 2002, incorporating subscap tendon with more than 60 degrees of the external rotation arm at side. This is my rotator interval closure procedure. This is exactly the same since 2002. And this is very demanding and very effective. So we're gonna publish papers the effectiveness of the rotator closure as an augmentation for precision athlete shortly this year. So green crack concept, bipolar bone loss, bipolar lesion, and the Hill-Sachs ADT. Maybe by rotator closure, we can reduce the number, increase the number from 83% to more than 90%. So the other option is Hill-Sachs ramp research. Ramp research is not my, it is not my today's topic, so that I can skip my talk. But ramp research, our ramp research itself is a little bit different from others. Ramp research procedure is also very consistent among surgeons. Our ramp research is that we're looking from the posterior bursa, and we place the sutures directly under direct visualization by scope, and placing suture to the same place like this. Okay, I will skip my video. So the options other than the bone grafting for obstruct region is arthroscopic bony bankart repair and augmentation, including interval closure and Hill-Sachs ramp research. So my conclusion is arthroscopic soft tissue or a bony bankart repair should be a bankart repair and capsular safe, not just a simple liver repair. And by adding augmentation such as rotator closure and ramp research, repair can be much stronger. Thank you for your attention.
Thank you, Hiro. Yeah, Ashish, you continue, please.
Questions?
Yeah, so the questions are coming. First question is that does he close, Hiro, do you close rotator interval in all the cases, or you choose the cases which are hyperlax and you do that?
I closed my interval in 80% of my patients. There are two exceptions,
Okay.
3 exceptions. Patient with more than 40 years old, because of post-op stiffness is concerned. And also another exception is thrower's dominant arm. So thrower need to be wide rotator. So that's 2 exceptions. So I think otherwise I close everything. So my preference is almost 80%.
Do you put just one suture in a rotator interval closure, or you put
no 2 or 3? 2 or 3.
Yeah.
2 or 3. Yes.
Yeah, Ashish.
Yes. Hiro,
yes.
Have you any thoughts on all suture anchors that you've used? Have you used them for your bankart?
Mm-hmm.
All suture anchors without implants?
Yeah. You mean suture material anchor?
Yes.
Yeah.
So do you use that regularly?
I use a biocomposite suture anchor.
Right. But you've not tried the all suture anchors?
No.
No.
I don't like that. I don't like that.
Okay. Yes. Good.
That's the reason. Simple reason.
Yes, I agree. And what is the percentage roughly of the number of remplissage that you do in all your bankart patients?
I think maybe my remplissage indication is that the young collision contact athletes. So maybe about age of the teens and around 20 years old. So roughly speaking, maybe about 10%.
Oh, 10%. So yeah, very few, right?
Hiro,
very few when compared with rotator interval closure.
Your camera is not working, Hiro. We can't see you right now.
Oh, really?
Yeah. So is it switched off or what? Pradeep? Yeah. Now it's okay.
Yeah.
It's okay. Yash, you had some questions.
Ashish, are you done? Hi. Or should I ask my question?
Yeah.
So, Hiro, congratulations, excellent work over the years. Now, you studied your 8 to 10 year follow-up and you published it in the JBJS in 2015. The other day, we heard Laurent Lafosse, and he said that his primary reason to do a Latarjet, even in the presence of minimal bone loss, is the concern that after 10 years, the dislocation rates are higher. What has been your observation from your group of patients?
It's totally different. So 10 years after surgery, even the patient remains very stable. And also we are now investigating the late of the post-op arthritis. So and in the process of looking at the rate of arthritis, the arthritis rate is a little bit smaller than Latarjet. So I think because in Laurent Lafosse, why he performed Latarjet for the small bone loss patient, Is the main reason is because he's French.
Your camera is again switched off, Hiro.
Yes.
Yeah.
And if you finish the answer, then I can ask you a second question.
Its camera is coming and going.
Hello, Ashish sir. Hi, Oberoi sir.
Hi, how are you? Yeah, Hiro's camera is not working.
I think there is some setting
But I
on.
can hear you. I can hear
Yeah,
you.
you can hear.
Okay.
Okay,
So
I can hear you.
Hiro,
Very
my
nice.
second question was that in patients who have multiple dislocations, when we scope the shoulder, there are patients where we don't get a good quality tissue. The labrum is there and the capsule is also there. So you can repair it, but it is a precarious tissue. Now, if you are encountering such a situation, would you think of doing a bony procedure or vis-a-vis add a remplissage, or will you just go ahead with your Bankarts alone?
So the Bankart soft tissue Bankart procedure is for soft tissue Bankart procedure. Is the capsule is very, very important. So the fragile capsule, the unreliable capsule, we cannot perform soft tissue Bankart anymore. But the capsule, normally most of the capsule remains in this patient. So that if the patient is very, very active patient, we cannot rely on the soft tissue Bankart. So that's why I do Latarjet. Latarjet is the only option because we cannot use capsule. But not so active patient, a little bit older patient, we can still have a chance of doing soft tissue because they are not so risky after surgery, and also so that's why I prefer to choose the less invasive surgery. So anyway, the capsule, very bad capsule, after kind of the big hydro region or other things, unrepairable capsule, I do Latarjet. But the prevalence is very, very small.
Okay, thank you.
Hiro,
Yes.
one question from me. For the Bony Bankart repairs that you do, does the duration of the Bony Bankart influence your decision to do a primary repair? If that Bony Bankart was 2 years old, would you still do a Bony Bankart repair?
Of course, doesn't matter. Doesn't matter. From the first time dislocation of the surgery, the time to surgery, is the affect the size of the bony fragment because bony fragment gets smaller with time. But sometimes the fragment unites very nicely to the medial side of the glenoid. In the situation, fragment remains very nicely.
Yes.
So that's why. So if the patient retains, kind of substantial size fragment, very small patient, very small fragment, big bone loss, very, very small, tiny fragment. In the active patient, we cannot rely on the bony fragment, but otherwise we can rely on it. It depends on the patient's activity and the pathologies, other things.
Often when arthroscopic Bankart fails after say 3 years or 4 years, they usually fail with a Bony Bankart because of the stress riser, because of the anchor. Would that behave very similar to a primary Bony Bankart?
Yeah, that's a different issue. I think that's a technical issue. The some surgeon, actually I experienced that. Some surgeon operated the Bony Bankart. Bony Bankart was soft tissue Bankart, inserting anchored little too perpendicular to the glenoid like this. Then they create the bony fragment, glenoid fracture after surgery. So that's I think a technical issue. So the anchor should be inserted like this, not like this, like this.
Hiro, what is your take on a double row Bony Bankart repair? You do a single row kind of repair with your instrument. So is there a role of a double row repair where they put a first anchor on the maybe neck of the glenoid and the second on the two more anchors on the
So
face?
I only perform the double row anchor Bony Bankart repair for the fresh fracture, big one, right? The chronic fracture, no need to do that.
And it was quite surprising. You showed us that the bone volume actually increases after repair, more than 100%.
Yeah.
So what's your take? Why does that happen? How does that happen?
Because I think in remodeling. So that we can successfully provide the circumstances for the shoulder to remodel by the retensioning of the entire ligament. The ligament pulls, then the fragment glenoid increases.
That's amazing. That's quite amazing, actually.
That's human being. Yes.
Yeah, yeah. So
They wants
let's
to go back to normal.
okay. So let's hear Ashish now. I mean, Ashish, are you going to talk about Latarjet now?
Yes,
Yeah.
sure.
Okay. So let's hear you now.
Okay. So there has been a fair bit of repetition on Latarjet, and we've heard Tibier, Pascal Boileau, Laurent Lafosse. And so I thought I'll not repeat my same talk, but I will speak on some newer aspects on the Latarjet. So we know that this was the study that changed everything in favor of Latarjet, where they had a high failure rate, along with the Jody Bear Burkhardt study, where they had a catastrophic 70% failure of Bankart repairs in athletes with bone loss, that's why I recommended that they should undergo a CT scan. And this was that study. So these two studies were critical enough to change the narrative completely from a lot of arthritic Bankart to going into doing Latarjet for most of. So that's why you will see Australia, South Africa, France, as Hero pointed out, are more inclined to offer Latarjet to most of their patients. And if you look at our series, I think like Hero, 90% of our patients undergo arthroscopic Bankart. Uh, I think the uh, surgeons who have a very good authentic rehab and are focused in restoration of normalcy, believe in anatomy, will still have faith in Bankart even in their contact athletes. And that is important to understand that that fragment has to get integrated. So for that fragment to get integrated, it is important to get that support, that bumper, so that the glenoid behaves like a trough. If you fail to integrate that fragment or get the labrum back in place, then it will be a little bit of a disaster. In terms of open Latarjet, I think there's a perception that the open Latarjet is an easier procedure than arthroscopic Latarjet, and I don't think so. I think it's a very demanding procedure and it has to be done very specifically. The pros and cons of the arthroscopic and open Latarjet are fairly similar, and I shall share that with you. But you will need a lot of experience doing an open Latarjet. You would need to understand that the open Latarjet combined with the Bankart repair needs a very perfect graft placement. It has to be congruent and it has to have two screws, and you must ensure that your hardware is not causing problems. The complications of a Latarjet can be far more disastrous than a Bankart going wrong. A Bankart surgery goes wrong can be revised with arthroscopic Bankart or can be revised with a Latarjet also. But a Latarjet that has gone wrong can go very badly wrong, and we'll try and see that. So it has to be very specific focus. And I have equal amount of stress whether I'm doing an arthroscopic or an open Latarjet on both ends. The take-home message I always send on is whether you do an open or arthroscopic Latarjet, we must endeavor to do an X-ray post-operatively to evaluate our precision, to evaluate the graft placement, to evaluate the screws and the alpha angle, to evaluate whether the graft is positioned in the inferior sector or not. And that is critical. Even in this open Latarjet example here, we will do an AP, axial, and a lateral. When it comes to an arthroscopic Latarjet, there are lots of issues. You must understand very specific steps. There are almost 10 hurdles that you need to surmount in terms of evaluation, exposure, preparation of the coracoid, then the coracoid osteotomy, which is a little diabolical and can go wrong sometimes. The subscap split number 5 step is considered very, very tedious. But to me, I think the transfer of the glenoid and alignment is the most challenging beyond all this. You will surmount all these hurdles eventually with the passage of time as you shorten the learning curve. And I per se believe in integrating a Bankart repair after an arthro-Latarjet, irrespective of whether I'm doing an open or an arthroscopic Latarjet. It is not always possible because sometimes the labrum is not present there, but you must make an effort to pick up the IJHL and capsule because that adds that proprioceptive augment to a nice bony procedure as such. So This is evaluation. The evaluation is always done not from behind, but from the anterior superior portal to be able to understand that this is a significant bone loss. You have a nice healthy labrum here. And obviously the premise is that if there's a bone loss, then soft tissue repair is not going to allow to augment a bone loss. So you cannot compensate a glenoid bone loss with a soft tissue repair. Then comes the issue about exposing the coracoid. This is a left shoulder. We have removed the CA ligament from the right side. We have put in our guide. This is the alpha beta guide. And it has to be positioned very precisely at an angle. The coracoid, as we learned on Lafoss's webinar, is not a straight organ. It is tilted in a very peculiar manner. And so both the wires have to come in an oblique fashion, and they have to be banked perpendicular to the direction of the coracoid. After which, evaluating the axillary nerve here is very, very important. It is mandatory. There is no other option that for you to evaluate the axillary nerve before you proceed to the next step, and that should be done in 100% of the cases. Then comes the subscap split. This is initially a challenging structure, but once you understand, the biggest error is to do too high a split. And if you do too high a split, then the graft positioning has to be wrong. You cannot do a high split and have a correct positioning of the graft. It is not possible. And you will extend it into the tendinous structure to be able to get a nice wide window so that your graft can slide in easily without any hassle. It is important to have the split done in a linear fashion along the fibers of the subscap, which will ensure that you will not face an external rotation stiffness, because that is very common if you split the subscap against the lines of force. This is the capsule which is attached to the subscap. So once the subscap is split, then you separate the capsule progressively, and you must keep the sharp end of the radio frequency away from the cartilage, because you don't want cartilage damage. Here, an internal rotation maneuver is important, desirable, to allow you to create space and prevent damage to the cartilage of the head of humerus. Then we start the preparation for the glenoid. Irrespective of whether there's a 20% glenoid bone or 15% bone loss, we have to freshen the sclerotic bone and ensure it matches the surface of the coracoid. So this preparation of the coracoid and the glenoid simultaneously have to be congruent. They have to meet up appropriately and manage it so that there is no mismatch between the graft and the host. This is the coracoid osteotomy. I do this much later in the later steps. You can do it with a stress riser using the burr. Initially, I just use a curved osteotome that's provided and do a clean osteotomy. It saves time, saves effort, but can be disastrous because it can, do a premature or fracture the coracoid. So you have to do it in a lot of patience and tenacity. And it should be fair distance away from that beta hole. Otherwise, if that beta hole is violated, it will compromise the screw hold on that. Once that is done, I think this is the most challenging step, that you capture the graft onto the blue cannula and then bring it in. The capturing is not such a big deal. The instrument design are very neat, and it's a few seconds challenge. But getting that graft to sit perfectly on the glenoid in the lower sector, parallel, congruent, flush, without being prominent is very, very important. So as the graft is positioned and once you're sure, then comes the fixation. So if your graft is congruent to this, it is very important here that your graft is not too low, otherwise the screws will be out. It has to be flush, and that's why your markings have to be done initially, and then you can see the graft and the actual native glenoid congruent flush in the same surface. So Joe Devier's statement that the coracoid was born for the Latarjet procedure is interesting. And once that is done, then I finish that off with a labrum repair along with after the screws have been positioned, but we have captured the labrum in advance. You cannot start doing the capture after the graft has come in place, because then it becomes tedious. I think this offers a nice proprioceptive interface to the Latarjet, So we are augmenting our repair and the tension, but it also tensions the inferior capsular tissues. Now try and get what I'm trying to say here, that you can have a Latarjet that is healed well, but is still unstable in the throwing position because the IGHL and the capsule provide inferior stability. If you were to do a Bankart repair to complement your Latarjet, then even in this position, the patient will be stable in neutral, mid-range, or abduction position. We always follow up all our Latarjet patients at between 3 and 6 months with a repeat CT scan to evaluate, study, ensure that the screws are in the lower sector, the graft integration, because the osteoslices has already started at that point, and you want to know and ensure that your alpha angles are not wrong. So we did our study, and our study was to evaluate not only the position of the graft and the angles, but we also wanted to compare our first 25 with the second 25 Latarjets and find out the learning curve. You will see here between the first 25 Latarjets, we had much more screws that were out in the first half and skewed. We had zero skew in the second half, and we had very few screws that were out in the second half. So our learning curve had already started improving. We are getting much more parallel screws in the second half here. If you look at the overall study, we had 80% of our grafts which are positioned perfectly, and 10% were in the mid-range. There were none of them in the high position. And that's largely related to the subscap split. As we got better, this improved. And so most of these are contact athletes and kabaddi players and military candidates. I cannot finish a Latarjet talk without explaining the perils and the pitfalls of a Latarjet. This is a Bony Bankart that was treated by an orthopedic surgeon with a rotator cuff in a 60-year-old lady. And when he had not done a CT scan and just on an MRI missed out the Bony Bankart, went in, did the cuff repair, and then freaked out and converted that into a Latarjet. So number one lesson from this experience is that never ever provide a Latarjet for a fresh Bony Bankart. A fresh Bony Bankart must be dealt with repair, and whether open or arthroscopic is entirely your call. But that will fail and lead to arthritis and screws damage in a 65. It was unnecessary to do a reverse shoulder replacement on this patient. This is one of my own patients, and I will deal with this when I speak about the next case that we are going to present. But this fellow stopped his medications and avulsed because he had an epilepsy on the 5th day of his surgery. He avulsed the entire graft, and that's why we had to redo this again. So it is very important your epilepsy patients are counseled, they are stabilized, and they don't stop their epilepsy management. This is a patient who's had an open Latarjet and the screws are out on the inferior sector. That is dangerous. The axillary nerve is right there in the neighborhood and can create a complete mess. Although the graft is integrated superiorly, it's a reasonable position. It's not done. And that's an error that can happen very commonly. A high screw again will lead to healing of the graft. This was a flush graft if you look at the lateral X-ray, but they tend to be much more stiffer in external rotation than the perfectly positioned graft. And this was a take Giles Walsh does in dealing with very high laxity patients. When he does the graft, he puts them a little higher to make them a little stiffer and prevent dislocation. But I don't agree with that. This one was done in Jodhpur and it was poor. The graft surfaces and the native surface did not match and it did not heal. And this patient dislocated again just like that. And so this is a challenge to revise a Latarjet as such. So the ideal Latarjet, you want an alpha angle of 15 degrees, lower sector, 2 screws, ideally parallel, and prove that it heals. X-ray pictures of Latarjet do not tell half the story. It is only the CT scan that will evaluate the Latarjet success in a much better, robust, and scientific manner. Now dealing with a few literature survey of the Latarjet. This is a nice study that I would like from Justin Yang, Mazoka's unit. They compared 2 sets of patients. One were primary patients and second were revision patients. One were treated with the Bankart remplissage and some were treated with the Latarjet. Now, when you have a subcritical bone loss, these are all patients with a subcritical bone loss. We're talking of 10 to 15%. You can go both ways, and there is no perfect answer that you have to do a Bankart and you have to do a Latarjet. From that point of view, the study was very well designed. So on the group A, which were the primary patients, both groups had a very good result, very comparable. P-values were not significant. However, in the revision patients who had failed Bankarts, the Bankart Remplissage group had a recurrence rate of 14% versus the Latarjet group with a recurrence rate of 8%. Complication rates in both groups were pretty similar, 36 versus 40%. For those who had asked questions about arthroscopic Latarjet being complicated, even the open Latarjet has a large failure rate or large complication rate. And this was the study I mentioned the other day, Shah and JP Warner and the Greiser study in JCS 2013, 30% complication rate with the open Latarjets. So do be careful. Don't take the open Latarjet for granted. I think both of these surgeries are critical. Most of the complications dealt with axillary and musculocutaneous and suprascapular nerve problems. Now question comes, should you do the conventional Latarjet, the Walsh technique, where you just pick up the coracoid and put it in flat, or should you do the congruent arc technique described by De Beer and Burkhardt, where you're rotating the graft to get the medial surface facing the native glenoid so that you get a larger arc here. So to debate that, I think this is a nice study from Joshua Dines, where he said that the surface available screws on the congruent arc is smaller. And that's why many surgeons are tentative. They think that putting 2 screws on the thinner surface is difficult in the congruent arc. However, the radius of curvature is much larger, wider with the congruent arc technique. And Joshua suggests that the congruent arc produced is a much better quality, so they match and mate very nicely. So for the long-term outcome, it is possible that the congruent arc is better. My take is if you have a minor glenoid bone loss of 10-12%, use the native technique, because then it's not making it too large and not putting pressure on the subscap. And if you have a larger bone loss like 15 to 25%, then you might use the congruent arc technique so that you get a much bigger radius of curvature on these patients. Lastly, these are comparison between a Bankart and Latarjet, again for subcritical bone loss, South Korea Seoul study, and they found recurrence to the magnitude of 23% with Bankart, much less recurrence in the Latarjet. Now, I understand we are comparing orange and apples. It is quite obvious that arthroscopic Bankart, which is a soft tissue repair, is always going to have a higher recurrence rate than a Latarjet. But the complication rates with the Latarjet are going to be higher than a Bankart because it's an arthroscopic Bankart. So you have, for those gray zone areas where you have a 12-15% glenoid bone loss, you have to choose depending on factors of age, if it's a male, if it's a contact athlete, if he's prone for failure, is a compliant or not, then move towards the Latarjet. If it's a female, non-contact athlete, pen pusher, age above 35, I would prefer to do arthroscopic Bankart even in those patients as such. The comparison between open Latarjet, arthroscopic Latarjet complication rates are very similar. Of course, these are very high-end surgeons who have a high volume of arthroscopic Latarjet. Complication rates were larger in the open Latarjet, but the apparition rates were higher in the arthroscopic Latarjet, probably because the soft tissue Bankart was not done in the arthroscopic Latarjets, and that could explain that. Again, Chunyanjiang, open Latarjet versus arthroscopic, similar rates, zero recurrence on both, operative time lesser with open, but the arthroscopic graft absorption was much lesser with the arthroscopic Latarjet, and this is what we have noticed in our series as well. So in conclusion, range of movement after Bankart Latarjet is no different, really speaking. OA after Bankart Latarjet are similar. Nerve injury rates open versus arthroscopic Latarjet are also similar or probably higher with the open. Return of sports is probably likely higher with the Latarjet, but that's the American study. If you look at Sugaya, if you look at Songo Kim and our series as well, we have enough patients who have had arthroscopic Bankart and still gone back to playing sports as such. So in conclusion, both are demanding procedures. Please don't use the Latarjet for a large, fresh, bony Bankart. If you see a bony Bankart, you must do exactly what Hirosuga has advised today. When you're dealing with glenoid bone loss, we don't know what is the upper limit, but 15% glenoid bone loss is probably my threshold for offering a Latarjet in these patients. You still need to qualify which technique you're using because there's a lot of divergence between different Latarjets that are done by different surgeons. Thank you very much.
Thank you, Ashish. Indeed, a wonderful presentation. Question for you specifically. Anytime now 2020, are you doing an open Latarjet?
Yes, IPS. What happens is we have a lot of poor patients that we're doing free surgeries for, and the hospital doesn't like us doing expensive procedures for them. The hospital provides a complete free service to them. So these are all done by my registrars, and all of them are 100% supervised because I don't like to leave an open Latarjet to my fellows. I will supervise them from the skin to skin for the open Latarjet. That gives them an opportunity to learn the Latarjet as well.
But the follow-up is nearly equal, whatever you have
Absolutely
done.
same. They
Okay.
will all have a CT scan. They'll have all have the same rehab. We try not to immobilize them. Nothing changes apart from. Results are also pretty similar.
Great. Hiro, couple of questions coming to you again. I mean, people are asking about subcritical bone loss. And as Ashish rightly said, we are all confused between a bone loss of around 15%, 18%, what to do. So what is your take right now at a bone loss which is around 15 to 18%? And what are the other factors you take into consideration in these patients when you decide for a Latarjet or a soft tissue procedure?
Yes, and of course, and the bone loss is one aspect.
Yeah.
So the bone loss, glenoid bone loss, and the Hill-Sachs lesion, and the patient's age and activities and the requirements, soft tissue qualities, everything get into should be into consideration. So then I decide. So my kind of critical area is it depends patient's activity, but 15 to 20%.
IPS, I
Yeah.
must say here that Hero is equipoised here because he does all his surgery in the beach chair position, including the arthroscopic. So whenever he is doubtful, he can position a patient for arthroscopic Bankart, which he does in the beach chair position. He can switch midstream to an open Latarjet. Those who are doing their Bankarts in lateral and their Latarjets in beach chair have to be very careful. They cannot be as casual. They need to make that determination in advance.
Absolutely. Hiro, do you do Latarjet or do you do a iliac bone graft?
I said, as I said, 95% soft tissue bunker with
Yeah, no.
with or without augmentation, and the rest of 5%,
Yeah.
I do 4% iliac bone grafting with capsule Raven reconstruction. The rest of 1% Latarjet. So Latarjet indication of Latarjet is no capsule, very bad capsule.
Right.
We cannot use if you cannot get capsule, then Latarjet. So that's why my Latarjet indication is very small.
So the anchors which you showed in your Bony Bankart repair, are the single loaded anchors you prefer or a double loaded anchors?
I actually I use both, and well, first and from inferior number 1, 2, 3, 4, I use 4 anchors. 1, 2, 3, I prefer to use a single loaded anchors, and the top one, which is inserted to the 2 o'clock position,
Yeah.
I use double loaded. So
most of surgeons here in India don't have a bone stitcher. So do you prescribe some special instrument, how exactly to pass through the bone piece? Anything which can help?
actually a bone stitcher, but I want you guys and purchase a bone stitcher from Simpson Nephew. It's easy. And also the before bone stitcher, I utilize an ideal pink suture grasper. Ideal pink suture grasper. But that instrument is very fragile.
Yes.
So that you may break. So that's why I made a bone stitcher.
Sachin, a question, Ashish, a question to you. I mean, 15% bone loss, as you said, is something where you predispose to arthroscopy Latarjet. But if he's an office goer, he's not a player, he's still young, but he's around 25, you would still do an arthro Latarjet or a soft tissue?
No. I told you 90% of my work still remains Arthroscopic Bankart. I have not done a Latarjet for a 10% glenoid bone loss. If I have a young female who's a doctor, intern, who's not an athlete, 15% bone loss, good labrum, I would still do a Arthroscopic Bankart. I still have a lot of faith in the anatomical procedure. If I have somebody who's 40 and above, who's unlikely to come back for recurrence, not a wild gym guy, because we have a lot of them, then I would still do Arthroscopic Bankart.
To question of both of you, when you do a bone augmentation procedure, either a Latarjet or a iliac crest graft. So Ashish, if your Latarjet fails for some reason, you do iliac crest.
Yes.
Yeah. And so Hiro, if your iliac crest fails for some reason, then you do repeat iliac crest or a Latarjet.
After failure?
Yeah, after failure. Yes.
After failure of iliac crest?
Yeah. If at all it fails.
So far, no.
Oh, it
No
never
cases. One case actually my fellow did, my partner did it, and I'm not sure how he devised that, but my personally, I don't have that.
No, that is true. But if we are in a case where there is an epilepsy patient has an epileptic episode just after the surgery somehow, and that whole graft is pulled off, and would you repeat an iliac crest graft or rather go in for an? It's a hypothetical situation to a Latarjet. Maybe Ashish, if you can also add on these.
Can I answer that question when I do my next case? Because part of the answer is hidden in there.
Okay, I think that makes sense. Yeah, that makes sense. I think so. Let's have an interesting case, which probably
IPS, can I please ask a question?
Yeah.
So this question is both to Ashish and Hiro, and I would just like to go back to this discussion on subcritical bone loss. Now, Yamamoto and E.G. Itoi's work has clearly shown that when the bone loss is 25% or more, then the soft tissue procedure alone is not enough, and the failure rate is very high. On the other hand, they have also shown in that study that if the bone loss is 20% or less, you can still go ahead and do a soft tissue procedure, and the failure rates are not as high vis-a-vis a 25% or more bone loss. So correct me if I'm wrong, this concept of subcritical bone loss, which is 10-15%, is only used in contact athletes. And that is the only indication that if you have a contact athlete or overhead sports participation, and if you have a 10-15% bone loss, in an ideal situation or in a regular situation, we would do a soft tissue procedure. This would be one indication to do a bony procedure because they are into that high level sport. So other than this, 10-15% bone loss in the other population would still amount to doing a soft tissue procedure. Your comments, please.
Yes, Shreyas, largely yes. Which are the high risk guys who are going to fail a Bankart? The young guys who are less than 20 years old, the athletes, the people who have failed the Bankart before. Those are the ones, and the epileptics. So these are the ones I would subject into a Latarjet. A 15-20% bone loss in an elderly person, first time dislocator, or it's unlikely that they will have a first time dislocator, but in a female who's not a candidate for recurrence, because if you look at the overall profile of our dislocators, we hardly see a female candidate. It's like 5% of our series. I'm still happy to do a Arthroscopic Bankart, but it's important on the MRI that they should have a good quality labrum. You go in and you don't see a labrum, and I need to make that qualification pre-operatively because my Bankarts are in lateral and my Arthroscopic is in the chair. So it's very awkward to shift mid position. Hiro, your take.
Ejito and the Yamamoto study is very excellent to showing the, how do we think about the bone loss, critical bone loss, bone Hughes-Sachs region, the glenoid defect. But that's only one aspect. So you're talking about 10 to 20%, 10 to 50% of bone loss. But so I want you to understand, want you guys to understand, soft tissue Bankart doesn't work by itself. Soft tissue Bankart combined with rotator closure, rempressage works very well. So that's why in my case, in 80%, I do rotator closure combined with soft tissue Bankart, and also 10%, another 10%, I do soft tissue Bankart and Hughes-Sachs rempressage and also interval closure. So that's why I can manage this kind of soft tissue augmentation by the patient with 10 to 50% bone loss and even less than that. And sometimes we can manage that to more than 15%, 15 to 20%. So it depends on patient activity and other things. So that's how we can think about everything patient's activity background, bony aspect, and also soft tissue aspect and everything. That's my idea.
The other thing, Shreyas, is that Yamamoto and Ito's study was a largely cadaveric study. At the end of the day, as a surgeon, we are answerable to the patient because you want to give them that one successful study. So you have to individualize all those factors as well. Hiro, shall we proceed with your case presentation?
Okay, sure.
Yeah, yeah. Still, Ashish, Hero is putting up. There is a question coming from Ravi Subramaniam. He says, "What is your take on Herbert Resch J. Crest graft?"
Right, that probably works only in Austria. We have a local version of that in Delhi, and there can be disastrous results. I don't think there's a substitute. The Latarjet has been extensively studied, proven. I would be very loath to do something other than a Latarjet.
Perfect.
Yes, we got your screen, Hero.
Yeah. Okay.
Yes, okay.
Can I proceed? Yes, I will show the two cases, very interesting cases.
Yeah.
Okay.
And this is my disclosure. Case one is this history, the 20-year-old male, Latarjet rugby player. The patient dislocated left shoulder 3 months ago during rugby, and after that, he did not experience no frank dislocation. The shoulder remained unstable and felt pain and weakness. Range of motion was poor during the first presentation and a positive apprehension sign. And this is the imaging 3D CT. This is 3D CT, and he has large glenoid fracture. This is a 3-month-old fracture, and the minimum displacement, and also he presents the Hill-Sachs region here. Hill-Sachs region. So I do same Bony Bankart repair. Okay, question is, how do you manage this? 3-month-old fracture, glenoid fracture, and also the no frank dislocation, but he had evidence of dislocation once, only the first time, and he has weakness in a kind of the UPS symptom. How do you manage this? I have a question to you guys.
Hero, if this was not a contact athlete, I would.
He's a rugby player, rugby.
If it was not, I don't mind conserving this because the Bony Bankarts heal well. But in a rugby player, I would do a double row Bony Bankart if it was fresh.
Okay. And actually, because he's a rugby player and complaining, kind of UPS-like symptoms, so that's why I proceed to the Bony Bankart repair. So this is my actual video. This is a left shoulder. This is a view from the anterior portal. And I released a big fragment from the labrum together with the from the glenoid, native glenoid together with the labrum like this. And not just releasing the fragment from the glenoid, but also the IDDs the inferior labrum in order to mobilize the fragment. This is very important step when we manage when we treat the bony Bankart shoulder. Okay, this is a view from the after release, after mobilization. You see, and the first anchor is going to the 6 o'clock at the face of the inferior glenoid. And I prefer to use Kasperi punch to pressing suture to the inferior portion of the soft tissue. And I first pressing two sutures. Oh, sorry. Now the big grasper is coming from the anterior superior portal. Now bone stitches coming from the anterior portal, and now try to penetrate. I'm trying to penetrating the bony fragment like this. So stitcher works very well. Okay. So this is after repair, the view from the anterior portal. Okay, this is the 4 months after surgery. Look like this. It looks like this. So anatomical reduction. So can I move on to the second case?
Yes,
Guys,
please.
just a question.
Okay.
Did you
Okay.
do a reptissage in such cases as well?
Oh, this case? No.
Yeah, you
no,
don't
no,
do it.
No augmentation. No augmentation.
Okay.
No.
Yeah, you
nothing
can go to
necessary.
the second case.
Okay. Second case, case 2, a 22-year-old man recreational snowboarder. The patient experienced first time right shoulder dislocation 13 years ago. This is a very quite chronic case during snowboarding. And he had a multiple episodes of dislocation, but all of these are self-reducible, and range of motion was full, and a positive apprehension sign. And this is the pre-operative CT, very large, severe, this is about 20%, around 20% bone defect, renal defect, and the Hill-Sachs region, medium-sized Hill-Sachs region. I think this must be off-track region. And the bone, he has bony fragment, but 13 years history he has. So that's why the bone fragment gets smaller when compared to the actual bone defect. How do you manage this? That's my question.
So this one is also an athlete?
Yeah, the snowboarder.
Snowboarder.
Snowboarder. Maybe no snowboarder in India.
Yes. No.
So I think Ashish, you would go in for a arthro-Latarjet such case.
Probably, yes. This looks like a very fragmented, and for a snowboarder, my preference would be Arthroscopic.
Okay, maybe many people, many doctors, many guys are gonna choose bone grafting.
Shreyash, what about you?
Okay, can I go?
Yeah.
Okay.
You're muted. You're muted.
Actually, I chose the arthroscopic bony Bankart repair. This is a very chronic case. A lot of synovitis, and the capsule tissue looks not so good, but still viable capsule he has. A lot of synovitis. This is a very old case. You see a lot of erosion of the cartilage erosion of the anterior limb of the glenoid, synovitis, very severe bone loss. So after release like this, and I use the exactly same procedure, same way, same step to fix this bony Bankart, and also I close the rotator interval. This is after, this is a view from the posterior portal after bony Bankart repair, like this. Okay. So this is a pre-op, pre-CT, 5 months after surgery like this, and 8 years after surgery. Look at this. Very nice bone remodeling.
Amazing.
Amazing. Yeah.
The reduction of the fragment.
Yes.
Is there a difference between the post-op rehab for a plain Bankart versus a arthroscopic bony Bankart like this patient in the first 6 weeks?
No.
Same.
Exactly the same.
Hiro, we always see you using knotted anchors. Have you used knotless in such cases as well?
No, knotless anchor. I don't use knotless anchor because I'm inserting the anchors to the 6 o'clock position like this, right? So notice anchors, once we make a hole, then we grab the soft tissue, then reinsert the anchor to the hole. But the angle is very difficult when we try to reinsert the anchor to this 6 o'clock, these holes. But we can reinsert the anchor here or here. But inserting this area, it's very difficult. So that's why I don't prefer to use that. So always.
Did you experience any suture cutout when it is passing through the bone fragment? Anytime it happened that when you're tying a knot, the suture cutout happened or something? Because sometimes it passes, never?
No, no. Bone penetrating instrument, then I use the bone penetrating instrument, bone suture, and pass through yeah. And I prefer to use the high strength suture, so the kind of things never happen.
Have you had the bone fragment
It become more comminuted once you pass your instrument through it?
Oh, it's okay. It's no problem because fragment is connected very firmly to the adjacent labrum. So if you create a fracture, you don't need to worry about that. Maybe you can promote the bone healing. So no need to worry about this.
And in this case, if there was no bony Bankart, it was a bone loss like this, would you still go ahead and do a soft tissue procedure in the snowboarder or a Latarjet, as Ashish said? If there were no these,
maybe if he has a big Cusack's region, I do Yakras grafting.
Forgot my. Sorry, I'll come back. IPS.
Question to you, Ashish, from Sunil. Do you use a bio screw sometime for Latarjet?
I have never used. I don't think they're available. Marcus Scheibel is using some of the foot screws that are made by companies for the hallux valgus and rigidus, but we don't have a dedicated biocomposite screw for Latarjet made for it. You know that Laurent Lafosse has used it for the superior hole, but then he uses the helix anchor. But then you need a long length and you need something that is about 32 mm.
Okay, so let's go back to Hiro.
So IPS, sorry, my question was regarding the rotator interval closure augmentation. So just to check this point again, so you keep the arm in around 60 degrees of external rotation and then you do the closure.
Yeah.
Okay. Fine. Thank you.
Coming back to your case, Hiro. Yeah. Sorry.
Okay. Sorry, this is going to be my last slide. To summarize the thing, let me insist the important thing is the extensive labor release. Even you have subacute granular fracture, bony Bankart, large fragment, extensive labor release more than the fragment and more than past 6 o'clock enables excellent fragment reduction. That's a very, very important step. And if you have chronic bony Bankart region, extensive labor release can enables the excellent fragment reduction and also ligament retentioning. And this provides excellent remodeling. So that's my very important message to you guys.
Great. I think the amount of remodeling which you have shown is remarkable, and 8-year follow-up of certain cases and 10-year follow-up shows how remodeling happens. It's an overgrowth of bone, which is quite amazing. Thank you, Hiro. I think Ashish, let's go to your case, and we'll have opinion of Hiro from your case as well.
Sure.
Yeah.
Okay. So wanted to show you a case with a glenoid bone loss. This is a 35-year-old recurrent epileptic, very difficult to control, and in great trouble because she has bilateral shoulder instability. We are dealing today with the right shoulder, where she has a more than 30% glenoid bone loss, and Hill-Sachs was 18/12/2. Twice she was admitted, and twice she was postponed because of the stress and anxiety she fitted on the previous day of surgery. So that was we had to send her back to the neurologist, increase her dosages, and then optimize her. And then she had almost a 4 or 5 month period during which she continued to dislocate and cause a further glenoid bone loss. Just a note here that about recurrent shoulder dislocation in epilepsy patients, I picked up these literature support. All of them have suggested that They will need long-term therapy. They don't need to be on medication forever, but it is very important to optimize their control before subjecting them to surgery, because if they have a seizure post-surgery, it can be a disaster. And you could refer to some of these guidelines on them. So that's why the challenge today on discussion is going to be when to operate an epileptic. Do we control them, counsel them? Some of them are on depression, some of them are tramadol-induced epilepsies. This is less common in our country, but USA sees a lot of them. What are the challenges? Would you do open, arthroscopic? What is important is that you must have a CT scan for all of them. This are cohort of epileptics. The last time when we wrote up our open Latarjet paper, we had about 23 patients. One had an infection that was a diabolical case, and I'd rather forget about him. That was an open, non-compliant patient that gave us a lot of grief. 3 patients had seizures after surgery. One of them, immediate aftermath that I showed you in my previous presentation, we revised him. 2 of them had seizures about 6 to 9 months after surgery, and their Latarjet had healed up and they did not have a dislocation on that side. One of them had a dislocation on the opposite side. So once the graft heals up, probably the repeat seizure does not have an impact on your surgical repair. Coming back to this patient, very impressionable glenoid bone loss. This female lady,
Wow.
30 years old, and that glenoid is almost sliced, and so very challenging. And knowing that her epilepsy is so bad, this was last year. This year, 3 months back, she came in and got her opposite shoulder, left shoulder also operated. We did the same procedure. But here are details, significant hill sacks, 23 by 20 by 4 mm. And the right glenoid measured only 16.3, left measured about 19.3. So one of the worst glenoid bone loss that I have encountered with. So open to the house. Let us have your opinion how to proceed with this case. Anybody? Shreyas, IPS?
Can you show us the Husak's region?
Sorry, Ashish, can you hear me?
Let me show what I
Yeah,
have here.
his hill sacks here.
This is the hill sacks. Huge. It was wide, flat, not deep. Let me see if I've got anything on the X-ray. On the striker notch view, it didn't look much, but it was significantly flattened there.
So Ashish, from your description, I would do a congruent arc Latarjet with a remplissage.
Okay.
Yeah, makes sense.
And
Because it will take care of both the problems and obviously.
Open to the whole panel, Sundarajan, Shreyas,
Sundar, yeah.
IPS. How many of you have combined remplissage with a Latarjet?
Yeah, Ashish.
I do remplissage and recurrence grafting.
Yeah,
I do remplissage. And I think remplissage is very important, not just the bony procedure. Remplissage is extremely important in this case.
Right.
Yeah.
Okay. So in my practice, with the Latarjet, the graft extending the arc of congruency, I have never done a remplissage in combination with Latarjet, even for bigger bone losses. This lady is about 1.5 years follow-up now. There's only one patient I was curtailed to do a remplissage. That was a failed Latarjet done outside in Bangladesh, and there was nothing else. It was done very well, so I had to use a remplissage for that patient. So we went ahead, we planned for an iliac crest as Hiro suggested. I have prepared this case specifically for a few discussions for the audience. This was our exposure of the nerve. It is very important to do that before doing the Latarjet. That's your axillary nerve there. So it's been exposed, seen correctly, and the musculocutaneous. This here is the preparation. And that was this was the graft. You can see this is the iliac crest graft. It is the rough surface. It is flush to the glenoid surface, and you can see, you can hardly see any air between them. So it's been uniform, no bump, no offset. and it's as if it is made for each other. So there's a trick and tip that I would like to share with you for this patient. Once that was over, as is my habit, I had preserved the labrum. So we cut the labrum on the top and pass the sutures and keep it parked in the axillary pouch so that it doesn't interfere with our graft. Once everything is done, the stitch is done, and we bring it up, hold it with ice tongs on the superior portal, and then fix it up with a single anchor to combine and complete a nice Bankart repair. So we pull up the IJHL also along with the labrum repair. So it adds about 15 minutes. The small tip that I realized, and I hit upon this very accidentally, it's not mentioned in literature anywhere, is that you flip the iliac crest graft. So when I take the iliac crest graft, the posterior surface of the iliac crest graft should go inferior, and the anterior surface should go superior. So we take a tricortical bone graft, and because the world is the limit, you can take as much as you want. We usually take a 25 mm superior to inferior length. The medial lateral length is usually 10 mm, usually, but we flip the graph. If you flip the graph, then you will see that it just matches imperceptibly. It's as if it is made for each other. And we did this accidentally, and then I realized. So since then, I have always done the iliac crest graph. Whenever I have done it, I have flipped it upside down, and I have noticed that each time the curvature matches it imperceptibly and comes through very nicely. We've not done a Remplisa. These are post-op X-rays of the patient, and as is our habit, we've also done a CT scan at about 4 months, and we've established both screws parallel, lower sector sitting nicely, and flush probably. The point I wanted to take was, number one, when I'm doing an iliac crest bone graft, often I do it like the Arthroscopic, but it is not easy because in an Arthroscopic, you have taken down the coracoid. So the whole anterior shoulder, which is not a joint, is all open. So your graft with the coracoid come in freely without tension. Here, because the coracoid and the conjoint are intact, there's going to be a lot of problem because there is no open area for the iliac crest graft to come in. Now, there are two takes on this. Mark Scheibel, and I'm sure Hiro also, whenever he does his arthroscopic Bankart, arthroscopic iliac crest, you can bring the graft through the rotator interval and pass it through. Then you don't have to worry about the coracoid being there. The challenge is always going to be the screws. So irrespective of whether you bring the graft through the M portal that we do, which is a fairly medial portal, or through the rotator interval, the screws have to come very medial, very low. It's a very low subscap portal that will always kiss the axillary nerve and come. So you must ensure that you have a shield or a plastic cannula to protect the nerves irrespective. For our cases, when we do the Arthroscopic way, we actually resect the pec minor completely. And that allows us to take the tension off the brachial plexus, and then it can come underneath the conjoint and then come in flush, number one. Number 2 point I wanted to make is I would never do a Latarjet in its truest sense in an epileptic because I learned it the hard way. The previous presentation, you realize that the patient stopped his drugs and he fitted on the 5th day. And when you do a Latarjet, the conjoint tendon is attached to the graft, and the biceps flexion can be so violent that the graft can come apart. If that dislocation or if that seizure were to happen after the graft has healed, our previous Latarjets were not affected. But serendipitously, we learned that if the patient lapses on his medication early post-op in the first 6 weeks, it can be a disaster. So we prefer to do iliac crest in all our epileptics so that there is no muscle attached to the graft. And that is a small tip that I would like to share. We think that the osteolysis is slightly more in our Latarjet patients, where we've used the iliac crest bone graft as compared to the coracoid grafts in the Latarjet. But we're not sure about that because it's still a short-term follow-up. We have only 2 patients in the iliac crest graft where the superior surface have osteolyzed as compared to the arthroscopic Latarjet. But the trick remains, when you're using iliac crest graft, just flip it and it'll match it imperceptibly. Thank you.
Thank you, Ashish. If you can unshare your screen. So there are a couple of questions coming in, both for Hiro and you. First question is, Hiro, don't you think a Latarjet is superior to a iliac crest graft? In Latarjet, you do have a conjoint tendon, which is also helping in a sling effect.
So the Latarjet, the content tendon is a very critical structure, and for the iliac crest grafting, and this is free bone grafting. So the capsule is very important. So that not just
Okay.
the free bone grafting, bone effect, and the capsule effect. Latarjet, bone effect, and skin effect. That's my understanding.
Okay. But don't you think iliac crest, because it's a free graft, the chances of it to get resorbed are slightly higher than a coracoid graft?
I've never compared that, but actually, yeah, I've been doing iliac crest grafting, and actually the resorption is very rapid. But that depends on the graft position is very critical, and also the screw angle. I'm using a screw, so that's why the screw angle is very important. If you insert the screw perpendicular to a little bit perpendicular to the glenoid, then a resorption occurs very rapidly because of the stress shielding or something like that. So that's why I always try to polarize the screw to the glenoid, and then I'm satisfied with my result.
IPS.
Yeah, Ashish.
The osteolysis is theoretical. It does not impact the results at all.
Okay.
And it will affect only the impact of the osteolysis is that if it happens over the screw area and the screw is naked, then it can do a lot of damage to the cartilage. So that is why you need to observe the osteolysis, so that in case it is advanced, then you just need to remove the screws. It does not affect the results of the Latarjet at all in any way.
A question to you, Hiro. You use a scissor to go from 5:30 to around 7 o'clock to release your capsule.
Yes.
So Dr. Maheshwari asked, can you use a radio frequency instead?
First, I use scissors and separate the raven from the glenoid.
Okay.
Then I insert the rasp, release the raven from the glenoid. And finally, I remove the soft tissue around the glenoid and release the soft tissue. I use the radio frequency.
Radio frequency.
So I use everything,
but
yes.
you release it with scissor first, and then a rasp, and then radio frequency.
Yeah, because normally it looks intact. The inferior area looks intact. So that's why first I need to use the scissors.
Okay, perfect. You're going to ask some question, Shreyash? You're muted, Shreyash. Unmuted. Yeah, no worries.
I think along Ashish's point of Marcus Scheibel iliac crest technique, if I remember it right, he said you put your two fingers,
yes,
insert the graft, to dilate it, and only then you will. So I think that's the way he delivers it into through the rotator interval.
In short, you need to be a good gynecologist.
Does Hiro do it the same way? You go through the rotator interval, or any other tips or tricks?
Hiro, your arthroscopic iliac crest graft, which approach do you take?
Yeah, graft introduction, you mean?
Yes.
Graft introduction from the rotator interval. A little bit open up the rotator interval and maybe 15 millimeter skin incision or something like that. And I use a special device to introduce the graft through the rotator interval.
Hiro, as you showed remodeling in Bony Bankart, did you see any remodeling happening in iliac crest bone graft as well?
Oh yeah, that's exactly that's a resorption. I don't know. I can say that it's a remodeling or resorption.
Okay.
But the most of the 60-70% of the graft resorped, disappear. That only the important portion remains. Yes. That's maybe look like remodeling, but I think that's a resorption.
Question from Chirag to Ashish is, Ashish, in a bilateral shoulder dislocator where there is a bone loss on both the sides, which method would you adopt for calculating the bone loss?
Right. Chirag, good question. We still use the same technique where we measure both sides, measure the AP diameters, but we don't have a threshold value, which is the norm. So we use the value from our cadaveric study that we published in the International Journal of Anatomy, that we take that the Indian constant is about 25 mm. So knowing that the AP diameter is 25 mm and then this one is 16.3, then we will calculate that this is a 33%. And our radiologists have the same values, so they will report it accordingly.
Perfect. I think, yeah. Any questions, Sundar? Any questions, Ranjit, Shreyash, before we close? And maybe concluding remarks then by Ashish. So I think
muted, Ranjit.
Ranjit, you're muted if you want to ask.
Okay. Hello. Audible?
Yeah, audible.
Now question to Hero. Do you do bony procedures for your Hill-Sachs defect? And if so, what are your indications?
Your sex defect?
Yeah.
No.
No.
For your sex defect, I only do the
Ramp research. Okay. Great. So Ashish, Rajiv, you have a question.
Yeah, Ashish sir, there is one question here. So, what is your sequence of CT scan, and how do you decide whether your draft is in delayed process of healing? Because when we do open Latarjet also, sometimes CT scan does not show good bony bridge, but patient is asymptomatic. So, what to do in those scenarios?
Right. It's a very good question. We've got 2 patients like that, and they seem to have delayed healing, but we followed them up. And instead of 3 months, then we got their repeat CT scan done at 6 months. One of them healed up beautifully. The other did not heal up. His graft is still in position. His screws are still in position. This fellow plays for the Baroda Ranji League, and we kept telling him that he needs to come back and we need to revise it, but he's just not willing. He's still performing, he's still playing, but we are observing him very closely. So it looks like a fibrous union. If it was a non-union, the screws will break or bend for sure. So we have waited for 6 months for some of them to heal up, and they have healed up. So it's not such a problem. If your graft is not mated well and there's gap between the graft and the screws will prevent union. So that is, then there is no solution for that.
Yeah.
Right.
Thank you. Yes.
So we've come to the end of this fantastic webinar. Hiro, we are very grateful to you for taking time out. I know it is very late in Tokyo right now and on a Sunday, but we really, really appreciate it. Arigato. What is important is the take home that you have seen some brilliant results from Hiro, even with a Bankart repair, which is very less likely that you will hear in Europe or America. So that is important for you to understand. Remain focused. There is still hope for the Bankart anatomical procedure. But the most important take home will be no bone loss, no Latarjet. That doesn't work. Thank you very much, Team IAS, Sandeep, IPS, and others. Thank you very much. We enjoyed this session.
Thank you, Ashish, for coordinating everything, and thank you, Hiro, for joining in. It was indeed very helpful because now we are in peace of mind that the way you do, we are. It's actually matching the way we think about it. But your technical tips about doing a Bankart well is very, very important. And I think your some of these tips of going all across to around 7 o'clock position, releasing the tissue well, and doing essentially a capsular procedure rather than just a labrum fixation is an eye-opening thing. And I think I must compliment you for such a wonderful presentation and reassuring our faith again back in Bankart. Thank you, Ashish, for coordinating everything. It was indeed a wonderful program. And thank you, entire executive committee, including Shreyash Kachar, for joining in discussions. Have a nice day. Take care. Bye-bye.
Thank you, Ashish and Hiro. Thank you.
Very much. Thank you, Hiro. Take care. Stay safe. Bye.
Bye-bye.
Bye-bye. Ashish, thank you. So, are we offline? Pradeep?
Mute कर संदीप.
संदीप म्यूट है.
Mute कर.
आशीष कहाँ गया? चला गया क्या?
सर आई थिंक ऑल लीव द मीटिंग.
या चल ठीक है, बहुत बढ़िया, बहुत अच्छा हो गया. तो ये क्या कल से क्या करना पड़ेगा? सबको अपग्रेड करना पड़ेगा क्या?
हाँ, अपडेट करना होगा. नहीं तो वो
कई लोग नहीं एंटर कर पाए. तन में भी नहीं ऐड कर पाया, वो कई सारे नहीं कर पा रहे थे, कुछ प्रॉब्लम.
वो जूम को अपग्रेड करना है थ्रू गूगल से करना होता है.
ओके, ग्रेट. Sundar is back on his traditional sofa.
Yeah, sorry, I came late. I fortunately came. I slept off.
So when we will go to Coimbatore, we will take. I think we will enjoy this sitting.
So, chalo ji, it was a good one. So I think next is on day after tomorrow. So we'll let you know once it is finalized. Yeah.
What is timing?
So timing would be around 7 o'clock because probably we still don't know how India is going to work from tomorrow. So we want most of them to be kept after 6 o'clock or 7 o'clock. Chalo ji. Okay. Bye.